Hello, good afternoon or good morning, everyone. Thanks for joining us again. Last week we talked about the CARES Act. This week we have two experts that are going to talk to us about COVID-19's impact on hospitals, and to always lead us is our very own Mia Keeys. So Mia, I'll turn everything over to you.
It'd be great if I unmuted myself. Well, thank you, Brandon, so much for, again, organizing this. You're in for another treat, everybody. First and foremost, we have to do something very important, and we can do it, quite quickly, but still, we have to wish our illustrious Brandon Garrett a happy belated birthday. He just celebrated his birthday yesterday. So happy birthday to Brandon. Happy birthday to you. And all of that, okay? So I hope you had a great day. There you go. So let's go ahead and turn to the issue at hand. We're talking about continuing our conversation on COVID-19 and all of the implications behind it. And today we have with us Dr. Jay Bhatt, who is a former chief medical officer at the American Hospital Association, and all things related to hospitals. He's able to bring us that perspective today. We're excited to have you on, Jay. We also have with us Rashard Johnson, who serves as the president of Advocate Trinity Hospital, as well as Advocate Suburban Hospital. And Rashard, we're really looking forward and excited for your perspective. So thank you both for joining us.
Thank you.
Thank you.
No doubt.
Thanks for having me.
Absolutely. So we're here to talk to you today essentially about how the novel coronavirus, COVID-19, is explicitly impacting America's hospitals and our overall health system. And more explicitly, how it's affecting the staff in there, the physicians, the nurses, the admin, and the patients who visit and frequent these areas, those who are on the front lines, those who have families who they go back home to their families, and so their families are also impacted. We want to talk to you about how COVID-19 is really evolving and rapidly changing the business of healthcare, how care is delivered within hospital settings, within community care settings, and talk to you about infrastructure and how the patient experience as well as the overall care experience. So we're going to go ahead and just hop right in. First and foremost, I just want to glean a sense of what you're seeing on a day-to-day basis compared to what was happening prior to the onset of this pandemic. And this is a question for you both.
Well, I can start off. Thanks, Mia. And one, just appreciate the National Minority Equality Forum for hosting this conversation, and appreciate the leadership of the team there. And Rashard, appreciate all that you're doing on the front lines with your team here on the south side of Chicago, a place that's dear to my heart. And, before I answer the question, I want to say, it's been incredibly inspiring to see how hospitals and their teams are showing up and how they're collaborating together in the light of this pandemic. We're seeing just incredible stories from the front lines and from the communities that they serve. And I think this has changed the approach that hospitals think about their care patients, because it's singularly focused right now on how we keep people safe and how we take care of them when they do show up in hospitals and are sick. And do we have the right equipment needed for our caregivers? Do we have the right team structures in place? Are we focused on organizing workflows and support needed so that we ensure that the care delivered is the best it can be, and it helps people get to health as soon as possible? And then, you're also beginning to see ways that hospitals work to deliver care differently. Virtual teams, the partnership between administrative leadership and clinical leadership, the work that happens with patients. It's often patients now are not in the room when COVID hits folks in a very serious way in the intensive care unit or even in the hospital floor. And so bridging the gap between patients and their families is really an important role that hospitals and their care teams are playing right now as well. But we're also seeing data emerge in a particularly interesting way. Who's getting sick, who's getting tested, who's not getting tested, who's recovering, who's not able to access care, and where are folks accessing care. And the whole growth of the virtual and digital health capabilities has been interesting to see. And I think that we've seen kind of the regulatory, the legislative, and private sector come together in a way to make it easier for hospitals to care for patients. There's more work to be done there, and I think we've got opportunities to go. But I would just end this point by saying, I think there are a lot of places where we can't turn back the clock as we move through this pandemic. We got to make sure that we continue to move forward because what's happened has enabled care to be delivered in the best way possible.
Yeah, absolutely. I echo those sentiments, and I'd say thank you for hosting this webinar. It's extremely important for us to have this conversation, and this is one that is very, very timely, especially given the fact that we are in the throes of the pandemic crisis and making sure that we fight this crisis to take care of our community. It's completely changed our operations from a hospital standpoint on a day-to-day basis. And when you just think about it, and we'll start first in terms of the team members that's impacted. It takes a multidisciplinary approach as you're taking care of patients or delivering that quality care and delivering that service. So it's more than just our physicians and our nurses. I think it's important to highlight the ancillary and support staff that we have, because you have EVS workers that have to ensure that we clean these rooms properly so that they're terminally clean so that we kill the virus that's present. You have to ensure that those who are doing your imaging services and x-rays and MRIs and CTs are properly taken care of. Your techs as well that are there in the ED, or your assistants that are working with the nurses, working with the physicians. I think, when I look at the pandemic, it just spans across the entire spectrum of our team, and it places you in a vulnerable position. And so for us as a leadership team, we make sure that our number one focus is, of course, on the patients that we take care of, but you have to make sure you take care of your team members and those frontline workers first and foremost in order to be able to deliver the care to your community. So I'll say that on that front, it's certainly changed. It's certainly heightened our awareness to not only the health of our team members, but also you got to think about their mental stability as it relates to their families and their loved ones, and what they read in the news, and ensuring that you're very transparent. I spend the majority of my time making sure that I'm palpable, I'm answering their emails. My leadership team and I get out and we round as much as possible, as much as safely as possible as well, following all the appropriate PPE. I think that's one aspect of it. The other aspect, when you think about the operations, our EDs have become flooded with COVID patients, and whether or not they come in under PUI, persons under investigation, and then we rapidly test them and they become positive, you have to make quick decisions in terms of how you're isolating people, and even within your own emergency department, how you're practicing social distancing. And that becomes a challenge if you don't have the necessary expanse of space that's there. And so operationally, how you're utilizing your units on the floors and designating them, designating COVID positive areas, designated PUI areas, designating negative area space for patients to safely social distance, and just working with your ORs. And it takes, every day we are meeting around the clock 24/7 in a concerted effort in order to address this. So it's wreaked havoc on us for sure.
Yeah, and Rashard, I would say that, the other thing that I've seen is the real implications of cutting elective procedures and surgeries have on the work of the hospital and health system. I think that COVID has disproportionately impacted safety net and rural hospitals who also rely on that for finances to support operations. And we're seeing, hospitals across the country be impacted by this. I'm just concerned, about how this impacts organizations to continue being there for their communities as the pandemic sort of goes and flattens the curve, and we continue on in the months ahead.
Yeah, the truth of the matter is, Doc, we don't necessarily know what the horizon holds, and that's the scary point, because you're right, the financial impacts will be exponential. There's no doubt about it. The majority of our funding, as it relates to our revenue, comes from those elective procedures, especially on an outpatient basis. And so when you take into consideration that component of it, it definitely has a bleak outlook for those. And then there will have to be decisions that need to be made from an operational standpoint as it relates to your service lines. And that's a picture that we continue to work towards. We're going to utilize our data to help guide our decisions to make the best choices in terms of our community and also our team members, because we are economic engines as well. And so that's a critical point to make as you look at our hospitals within the communities.
I think you both are making some serious points that I want to pick up in terms of questions. So Jay, I want to start off by starting with the line that you just mentioned about our safety net hospitals. And eventually I do want to come back, Rashard, and talk about not just the physical wellness implications of COVID-19 in terms of patients and physicians and their families, but also the wellness, the fiscal wellness of hospitals. So we'll come back to those two, or to that. But Jay, let's start with you, and Rashard, I want to then also bring you in on this. Talk to us about our safety net hospitals. And when we're talking about safety net hospitals, we're talking about those hospitals with the highest rates of uncompensated care. These hospitals are the ones who see and receive the most patients who are either on Medicare or Medicaid covered, or they're uninsured altogether. And these are also the hospitals that operate at about a fifth of the financial margin of hospitals around the world that are not considered safety net hospitals, right? These are hospitals with disproportionate share status eligibility, which impacts resource distribution. And these are hospitals that are also doing all that they can to meet the needs of those patients who are historically medically underserved, those who are most vulnerable to chronic conditions and acute conditions that make them even more vulnerable to contracting COVID-19. So please talk to us about how COVID-19, first and foremost, exacerbates these pretty normal but also distressing conditions of essential hospitals, and what needs to happen moving forward in order for essential hospitals to continue delivering state-of-the-art care to patients while also protecting the wellness, physical or otherwise, of their physicians and healthcare professional staff.
Sure, thanks, Mia. And I think COVID has illuminated the issue of a lack of investment in essential hospitals and some of the infrastructure that's needed. I mean, we're seeing right in New York, on Ground Zero, Elmhurst Hospital, which is part of the New York public hospital system, how this pandemic is impacting that hospital's caregivers, their patients, and their community. And so, its impact from not potentially having the right resources or care workflows that are needed to help people be healthy, I think, and take care of them when they're really sick. The challenge can be is that people that are disproportionately at risk for getting sicker and dying are potentially showing up in these essential hospitals because they're connected to getting care there. They are vulnerable, and in times when we're vulnerable, we don't know where to go, but we go to the place that's there in our community. And so, I think it's critically important to provide resources and support to the essential hospitals to manage through this, but also outline what are the implications for moving forward in the future, because it's a matter of both leadership, resources, and can we support them to restructure their operations in a way that can help them be successful moving forward. And that comes from both their peers, from other hospitals that are maybe have other resources and learning that they could share, but also from a regulatory and legislative standpoint. I think that there is a lot that needs to be done. Now, frankly, some of those organizations need to adapt and change who they are so that they can better serve their communities in partnership with other care delivery entities in that service area. And I think that it's some of what we saw with community health needs assessments. Those places where the hospitals worked effectively together and pooled resources and shared helped improve the outcomes of the community. And so, I think there's an important opportunity here for us, again, to not dial back the clock but move forward so that underserved populations are better cared for, and that we can try to advance health in this country as opposed to sick care.
Yeah, I mean, I agree. I agree wholeheartedly. I think when you look at safety net hospitals, in order to really delve into the impact it's having on safety net hospitals, I think it's important to talk about the mission of safety net hospitals and the way they're currently structured. You know, as safety net hospitals, your mission is to take care of the vulnerable and those who have an inability to pay regardless, right? To provide top-notch quality care. And oftentimes you do so, to your point, Mia, with very thin margins. You have to ensure you have the specialists, the nurses, all of your physicians that are employed to deliver this care. And then your reimbursement isn't as robust as it is if you're in better payer mix areas or suburban areas, if you will. So I think the other compounding factor to that is oftentimes as safety net hospitals, to Dr. Bhatt's point, is oftentimes the community comes in once it's a chronic illness or it's essentially too late. So stage 4 of a particular disease. And so that emergency department becomes the primary care physician, and you don't have those preventative resources to help cope with those comorbidities before it's too late. So when you compound all of that and take COVID, it creates a very a high mortality, not a good recovery rate for our patients. And then you become beleaguered within that emergency department. What that does is it provides a strain on your operations in order to take care of not only those related to COVID, but then those who normally would access you for services. So now you have a gap in access to quality care and access to services because your resources are constrained dealing with a particular patient population. To that end, I think it's extremely important for us as partners within the community. I'll tell you, in Chicago, myself as well as the other safety net hospitals that surround the south side of Chicago, oftentimes on the phone with each other and sharing resources as it relates to cath lab resources or PPE, and if you can, resources with community health workers helping out, FQHCs, et cetera. And I think that part of it, I will say, has bonded us together, has made us stronger, and we all realize that the greater good or the mission that we serve for the people is more important than our competitive, normal competitive process as it relates to taking care of and delivering quality care.
Rashard, do you also see, really quickly, do you also see a similar cohesion occurring between essential hospitals and non-essential hospitals? Are you connecting in a different way under these circumstances?
Yeah, I think absolutely. I would say that. I mean, for us, so I'm responsible for 2 hospitals. None of them are considered safety net hospitals, even though one of my hospitals, which is on the southeast side of Chicago, the other is in the southern suburbs. But we have safety net numbers in terms of the patients that we see. However, so when you talk about essential versus non-essential, there's a fine line there. And I've been in contact with the University of Chicago. I've been in contact with other safety net hospitals, Jackson Park, that's around our immediate service area, and we're partnering at a greater level than we've ever done before. The other thing that's helping us out a great deal is our local leadership here with the mayor, as well as state leadership with the governor. I think they've done a tremendous job working with the Illinois Hospital Association, bonding and bringing all hospitals together. And we do weekly calls, whereas the hospital CEOs are sharing best practices, talking about policies and procedures, and ever-changing practices as it relates to taking care of this pandemic.
And I was just going to add to Rashard's comments, one of the key issues for central hospitals also is testing. I mean, I think we need to be able to test those that are at risk and that are coming through. And if there's an inequity in testing capabilities, that has implications, for the hospitals to be able to take action the ways that they need to keep not only those individuals moving towards health, but keeping the community safe and the city safe and the state safe in terms of contact and social distancing and so forth. So I think, the tests, both PCR and the antibody tests, have implications for what we can do.
Yeah, you are. I mean, that's spot on. And the reason it's spot on is because we've progressively gotten better with testing as it relates to having commercial tests. In the onset of this pandemic, we were relying on the state solely, and the state was inundated with tests, as you can imagine. And so there were times where you didn't have results for a week, for 5 to 6 days on a patient. And that, and if you're pending results, you have to operate at the highest level of precaution. And so that becomes taxing on your resources. So the quicker we get tests in, the more we can logistically do the things that we need to do, whether or not it's ensuring it's full PPE to where we allocate our patients within our operations and keep social distancing and keep our general operations moving in a productive manner.
Let's keep on this theme of testing and as it relates to patients who present at either safety net hospitals or they themselves are really on the cusp in terms of their vulnerability. What are some ways, or not necessarily best practices, but what are models that seem to be working in terms of engaging patients who wouldn't otherwise come into a health system, but may need to be tested? Are there creative or unorthodox ways that you all are employing or have seen employed to ensure that the people who are likely the hardest hit or more likely to contract COVID are being tested? Is there messaging that will reach hard to reach populations? What are you seeing in that way?
Yeah, I'll start off with this one. As it relates to testing, I think there's two approaches to it. The first is we have to make sure that, there isn't an infinite amount of resources for testing, right? So if you're dealing with a finite amount of resources, you have to make sure that you're using those appropriately, especially for those who are symptomatic, who have been exposed to COVID, and those who are acute. And so that's what we're reserving our hospital settings for. Is for those who are coming in symptomatic and are acutely exposed to COVID and in need of help. That means they're presenting with a fever or any of those symptoms related to COVID. Now, we've received a lot of questions from our community, and we work with our local aldermen, our local state reps and legislators on pushing out information around local community testing sites, whereas you can go in and say, hey, I have a loved one who has been exposed, or I think I've been exposed to COVID and I need to be tested. I just want to be proactive. And so those resources are there within the community. We're in the process of ensuring with our local legislators that we up those resources and we provide more sites for that. But I just think, with that particular testing model, it's going to take partnership with the community in order to deliver the need, because you just can't have everyone flooding the ED for testing. And keep in mind, if you're flooding the ED for testing, then the ED is a hot spot for COVID as it is now, and so that increases your chance of exposure.
So I would agree with Rashard's comments there. Spot on in terms of the frontline perspective. I would say some of what I'm hearing and seeing in terms of effective strategies on this is one, using the community influence and people and organizations as partners to get messages out. And so we're seeing interesting ways, whether it's through social or through their connected networks, or you might have in the ways that we think about, campaigns, captains in various parts of the community that can make phone calls. So that's, one, and drawing upon faith-based environment or places that people find connection and is part of their community. The other is the tents that Rashard spoke about. I think different places of testing, so that you create some distance between the emergency room and potentially COVID positive individuals that are being tested. And then even within ambulatory clinics, particularly seeing this in community health centers where there are different areas kind of in these suites, pods, so that people know where to go. And it separates kind of non-COVID from COVID suspected to positive. And then, how they workflow with those patients into more care that's needed. And then community health workers being used in various places to do follow-up and make sure they're checking in regularly on suspected folks that are at home. Or, those are the other ways. The other interesting piece is around the homeless. And so, how do we get homeless tested, but how do we get them also in places where they're not a threat to their own health, but to the population? And so getting, space that hotels and partners that hospitals may have, or even in the hospitals themselves, where they have additional building space to house some of those homeless individuals. But that's a group that we got to think a lot about in terms of the impact that they may have on themselves and others in their community.
Let's stick with this theme, right? Because what you're both talking about is essentially social determinants of COVID-19, right? Social determinants of health in general, but more specifically how the pandemic really does exacerbate the conditions that were already with us before. So those who are experiencing homelessness, you have patients that might be presenting with food insecurity or transportation insecurity. You have patients who outside of the healthcare setting are spending a lot of time in their worship centers, right? And we know that health is essentially a combination of where you live, where you play, where you worship, and all of those things. So can you pivot a bit and talk to us about non-clinical ways that in this situation especially, hospitals are serving the communities, are anticipating the needs of the communities, and if there's nothing necessarily that's happening right now, are there plans for certain hospitals to be tending to these social determinants or connecting? Are there pathways of connecting patients to food resources or to housing resources or to transportation and such like that as it pertains to COVID and in the long term?
Yeah, I'll start with this one. I'll tell you that and I'm extremely proud of this fact, but we've been well on our journey to what we consider whole person health. And that whole person health means meeting the consumer, meeting the patient where they are within the community and exactly understanding what health means to them, whether it's their effective diets, whether it's access to care, whether it's working with faith leaders within the community that they attend, or set up screenings and protocols and getting outside of your four walls to do that. You're absolutely right. COVID-19 it places a keen and a prolific spotlight on the gaps and inequities of healthcare, the gaps to providing quality coverage that's there, the infrastructure that just isn't there in many of our minority communities, and then it exacerbates those comorbidities. So our community health needs assessment here on the south side of Chicago, we do it every 3 years, and we're federally mandated to do that. And that's what we build our operation plan and our strategic plan off of. It highlighted three chronic illnesses. The first was asthma. The second was diabetes. The third was hypertension. All right. And so if you go back and you look at all of the vulnerabilities for COVID-19, where the mortality rates spike up, it's involving those patient populations. And so for us, we've already started partnering. We have a healthy food pharmacy, whereas our physicians can actually write a prescription to patients, and they can come in and receive fresh cooked vegetables. We consider ourselves a food desert because you don't have all the grocery stores that you can go to, but there are fast food restaurants on every corner here on the south side of Chicago. So this provides a safe haven for patients to come in, but it's more than just the access to those vegetables. But I'm an African-American male, and I'll tell you, we didn't grow up eating healthy. All right. And so it's how do I make these vegetables applicable to me, whereas it's soul food like. And we have physicians that are help with that, and dietitians, and which has received rave reviews. The other thing I like to highlight for us in terms of our partnership with community and faith leaders for whole person health is we have a project called Imani Village, whereas we partner with Trinity UCC here on the south side of Chicago, and we built out, so we bought a plot of land, but we also built out primary care center where women can go in for OB care, where men can go in and receive primary care services and physicians. But then we also did healthy gardening that's there. We're working on affordable housing as well. And so it's all encompassing into our needs of addressing social inequities and the gaps in healthcare, and so those comorbidities. And we chose the Pullman area in particular because this was an area where the residents within the area were, if you look at Chicago, it respectively had the highest amount of diabetes, highest amount of obesity, highest amount of COPD. And so it's a direct aim at addressing those social inequities and determinants of health. My hope and my prayer, and what I believe will happen, is as this COVID-19 has shed light and over the exacerbation of that, is that we'll have more of our health centers and more of our partners within our communities of minorities that are coming together to think proactively, to think how do we address these outside of our four walls before they become train wrecks coming through the ED.
Yes, I would echo Rashard's comment. The only thing I'll add is one of the things we're also seeing is, in 5 states as a result of what happened in 2016 on the Farm Bill, SNAP now can be used for digital food delivery. And so that certainly is one way that folks are getting access to food without necessarily having to expose themselves to potential virus or expose others to virus. And that's things like that can be really helpful as well. We're seeing this, even on the issue of isolation, who I think people are disproportionately affected. We're exacerbating isolation in this case, where people are separated from their loved ones, or when they're in the hospital, they can't connect with their families or even their friends. Sometimes people won't have families, but it'll be that few friends that are their lifeline in terms of connection. And so we know that isolation has an impact on health outcomes. So I'm seeing long term that my hope is that this isn't just a conversation for the moment, that it really is an opportunity to redesign how we think about our health system to serve the most vulnerable but provide affordable, equitable, high quality care. And I think that it's another opportunity to illuminate the difference between social needs, social determinants, and health equity, which are 3 different constructs with some overlap, but I think they're getting mixed together in some parts of the country and by audiences. And so hopefully we can use this as an opportunity to talk about that. I think we're also seeing that some of the billing data in several states found that African Americans with symptoms like cough and fever were less likely to be given one of the scarce coronavirus tests, even though that might be an indication for that. And so delays in diagnosis and treatment can be harmful, especially for racial and ethnic minority groups that have chronic disease, that these chronic illnesses can lead to more severe cases of COVID. And so I think it's really important that we not only think about the social needs, the determinants, and also think about how do we improve neighborhoods that people live in, but what are the issues around unconscious implicit bias and health equity that we need to make sure that are raised to paramount.
Jay, you're speaking my language. And speaking of language, I do want us to take just a quick moment to talk about the difference between equity and inequities, more specifically, and disparities, because we do tend to, if we're not careful, flip between the term disparities and inequities. They're very different concepts. And for the sake of this conversation and for all conversations moving forward, we should be very clear that when we're talking about disparities, we're talking about natural differences. A disparity is a natural difference, a difference between birth weights of babies who are boys compared to birth weights of babies who are girls. On average, baby boys weigh less than baby girls. That is a disparity. It's something that is unavoidable, right, on average. Whereas inequity refers to a condition that is a direct result and a long-term indirect result of different avenues, whether those avenues be policies that are inequitable, or they provide power or resource distribution or prestige to one community over another. And so any outcomes in terms of health that occur are unnatural, and therefore they are avoidable. That is an inequity. That is not a disparity, right? So I'm really conscious about my language when I go and talk to people about this, and I just want to set that aside for the audience. I don't have a follow-up question to that, but I do appreciate you delineating between social needs, social determinants of health, and inequity, because and equity rather, because they're very different concepts. If we had time, we could have a whole linguistic class and conversation essentially around all of that, because it is necessary. But I do want to pick up on, actually my very last question to you will be to what you've been pointing out in about 3 or 4 of your answers, you've been talking about the future of healthcare. So that will be my last question for you. So just get your wheels turning with all of that. But let's go and talk about, you mentioned the thing of language, you mentioned the word separation, and one of you said something about neighborhoods and segregation. And it just got me to thinking about, again, inequities compared to disparities, and how historically, and you can see this in Chicago a lot, there's certain neighborhoods that are, if not all persons of color, then for the most part, right? And there are some things that follow there in the neighborhood in terms of what people have access to and what they don't. So usually when we talk about the term segregation, it has a negative connotation. But in the healthcare setting, with respect to protecting patients who are presenting with COVID from becoming even sicker, or from infecting, or not even infecting, because I hate that term, but spreading the virus or exposing others to it, segregation, safe segregation, is actually not an ironic term in that space. So if you can talk to us about the different models of safe segregation, or how do you help to let patients know, those who are presenting with potential symptoms, or if they're just coming in for some acute crises, how do you reassure them that that they will be okay in one section of the hospital compared to another, or even if someone's just trying to visit or accompany a person who needs care, what are some safe segregation tactics that you all are seeing in hospitals?
Yeah.
Otherwise, I don't like the term segregation.
Yeah.
No, that's a great question. To your point, we stay away from segregation, just given the connotations they can have, and so our terminology is more cohort, right? Cohorting our patient populations together, and I think so. We do it in a number of ways. The first way is your ED that's your front door. And as always, your front door to any hospital, but even now, more so now, that is the first stop for taking care of COVID patients or those suspected of COVID. So in order to ensure that we have the proper structure, we've set up like an ED overflow tent that supplements our ED, whereas it's strictly for those patients who may be under investigation from COVID, but aren't as acutely ill to where they need to be in ICU care or in isolation care, if you will. So that's one section for us. And then in our respective EDs, to the best extent possible, we've gone and we've worked with our infectious disease doctors. We've worked with employee health and our nurses and our chief physicians, just to make sure that we allocate the beds appropriately, and one that's efficiently for those doctors and nurses working in that unit. I think it's important for us as administrators not to sit on a top-down approach, but to say, what do you need from us? What resources do you need, or what works best, and how we allocate patients. So we do so in our ED. We have a section for patients under investigation, and that's really where the test is administered. And then now we're getting tests back in a quicker manner, to Dr. Bhatt's point. And once we receive that test back, now we're making decisions, whereas up on our floors within the hospitals, we have our ICU, which is designated for COVID patients, and then we also have overflow COVID units. So we have 2 COVID units and then and a possible overflow, and we designated a unit for patients under investigation. So if we're still waiting on the test result to come back, but we need more space for ED for more patients coming in, then we will move those PUIs up to that unit where they're waiting for results. And then we have a unit designated for those who are negative when the results come back negative, whereas it becomes this ever so moving cycle of efficiency in order to make sure that you cohort your patients in a possible manner. Because if you tested negative, then we need to move you from that PUI unit because there may be patients on that PUI unit who will test positive. And so we don't want to increase your exposure. And then it also enables us from a PPE standpoint to assure that we're being stewards of our resources. So it's actually, it's more art than it is science, to be honest with you, because it's ever evolving and changing. And a big part of it relates to our team members and the feedback that they give us back in incident command with the resources that they need. Because at the end of the day, you can scientifically draw up your plan, but you have to make sure that those caregivers feel comfortable. You have to make sure that they are empowered and they're a part of the solution in order for you to deliver the highest quality care. And so we're forever tweaking as we go around and we get feedback, and they're calling our incident command center. We tweak our processes with our operations, but that's where we stand as far as today is concerned.
For the incident command center, in what languages can people access help?
So we actually have interpretive language services here, whereas we have these workstations on wheels where we can roll them in the rooms and with the proper PPE, and we can utilize that with our interpretive languages services. And so we go across the spectrum with all languages, to be honest with you. I mean, from that standpoint, the majority that we'll see coming back is Spanish. Chicago, so we're able to translate that. We do have some Creole that's there, but these machines are high tech, high quality, and that's something in our daily safety huddles we report out on those patients that require interpreter services and making sure that we have that modality and that technology that'll serve them.
Yeah, but just great insights there, Rashard. I would say a couple other things to consider is the understanding your community and having the right language prompts that help make it easy for people to do the right thing when they show up at various care settings. The other is, this is an interesting opportunity, I think, where patient and family advisory committees could come to play. And I have seen some hospitals do that. It's not widespread, but what role can those PFACs play in helping provide consistent messaging, reassurance, compassion, empathy, support to the patients that may be engaging in the care delivery system? So I think a lot of opportunity there, and I think just reliable, consistent messaging that's culturally sensitive to the community that you serve is important.
I really appreciate the term opportunity here, right? Because COVID-19 we can definitely see the tragedy behind this, the ravages and such like that, but there is opportunity in crisis to, as I'm hoping we can talk to before we end, there's opportunity in crisis to really evaluate what our health systems needs and where the gaps are in terms of meeting the medical need with the social needs and the public health needs all together, right? But I want to pivot a little bit and talk a little bit about what we're seeing in media. A lot of people are learning about COVID-19 related issues from the media, right? They're not getting it directly from their providers initially, right? They're reading articles, they're talking to friends on social media, that kind of thing. And one of the articles or one of the topics that's been circulating the media has been around plans that hospitals are putting in place in terms of do not resuscitate and in terms of COVID-19 patients. So can you talk to us a little bit about these DNR plans that are popping up and whether or not there's any tie to CMS waivers or demonstrations and such like that, although it's a hard topic to have.
I would say that there's what I've seen from CMS has really been encouraging about conversations around how can care models be different for the future, and what are the opportunities to think about the continuum of care and supporting virtual and home and post-acute care differently, but also within the hospital, knowing that not all things are created the same across the country, and that there may be specific needs that different organizations and communities have. And I think the ability for clinicians to practice and make it easier for them to do the right thing, I think we should continue to support. And even the simple issue of reimbursing telephone visits the same as a in-office visit can make a real difference for I think organizations that serve safety net communities, because of the impact that patients might have of taking 2 or 3 buses to get to their appointment, or not that, other things that are happening in their life that are critically important that day, but the ability to keep connected to them via phone, who they may not have broadband, to have access to telehealth and internet. I think those things, can be really impactful for the communities that are underserved. And so I think it's going to be important to take lessons from this and say, what are some of the bright spots, and how do we test that further and give flexibility to design new models of care that better meet the needs of vulnerable communities. I think managed Medicaid and Medicare Advantage, and particularly the institutional special needs plans, are going to be really important ones to support for the populations that we're talking about here.
Yeah, I agree. I agree wholeheartedly. And Mia, I'll say you resonated something that touched, really piqued my interest, because I actually had this conversation with my wife in terms of media and what's reported out there. And, she was challenging me versus what she was hearing in the media versus the experts that I actually work with every day. And at the end of our argument, which she always wins the arguments, but at the end of our argument, I was, it sparked something in my brain, and I came back to my team and I said, guys, we really have to make sure we do just a more above and beyond job of being transparent and communicating more proactively to our team members and our physicians, because as I stand here, and though I may be the highest ranking executive that we have, my wife is challenging me on what she hears, and saying, yeah, I know you're working on this, but this is what I heard in the media. And I think it's important for us to make sure that not everything that's in the media is good data that's being reported on as it relates to COVID. So in terms of the DNR aspect of this, this is something, whereas we haven't enacted a universal DNR. I'm not familiar with it being tied to Medicare waivers or anything, along those lines. But from our standpoint, we look at this thing from an ethical and a moral imperative moment. And so what we've done is we've aligned our ethics team, and which is led by our VP of Mission and Spiritual Care, and it's all denominational. Our faith covers as it relates to taking care of our patients, and our ethics team, working with our physicians, are making critical decisions and working with the family on those DNR protocols. I read up on it. I know the concern. The concern behind it is whether or not you have the resources that's necessary, and then when someone codes, and Dr. Bhatt knows more so than I am because he's the clinical expert, when someone codes, there's a rush of resources that are needed from the code team, thus putting everyone in danger to the respiratory droplets and all the other bodily fluids that's encompassed into that code. So the question it comes down to is, will we not have enough caregivers? Is that exposure too risky in order for us to begin to deliver quality care? And those are tough decisions to be made. We haven't gotten to that point, and I don't foresee us doing universal DNR with my organization. But I think it's respective to each organization and that community and what they're seeing in times of crisis. I think that's a hard call to make.
Yeah, and I'll just add the media. I think the media, we have to challenge their assumptions, because there are different ways that they're coming about this, and that the science is critically important. And to just, it's important to rely on the voice of science and what the data show. And I think that there are plenty of sources for that that are emerging, but also it's a straight talk. And I think, Rashard, you were spot on when you said we got to have transparent communication consistently, reliably, and often across our teams, because that's what people need, is that they need that communication and messaging to be oriented to the uncertainty of the moment. And I think that on the DNR piece, I think it's looking at this crisis standards of care that states have, that hospital plans may encompass, as well as the ethics policy. And then, we often also need to remember that people may have exercised their wishes on the forms that they have when they come in. So when people come in, we should also look and ask them what matters to them and what is it that they want. And so we're not unnecessarily doing things to people that didn't ask for it. And so in the thick of kind of crisis and moving fast, you may sometimes forget that they may have already articulated what they wanted and in their care. And so I think that's important. And I think asking patients, what matters to them through our age-friendly health system work that we've been doing around the country, deploying a model called the 4 M's, which is mentation, mobility, medication management, what matters to you. That's really been patient and family preference has been important. Now, it's a little challenging in this case, given that sometimes visitors are not allowed and family isn't there. So it relies really on having those conversations. And sometimes things are moving so fast that you can't, have them. But I think the allocation and ethics of resources, that's going to be a conversation that continues to evolve.
No doubt. It'll certainly inform how we need to move forward. We are going to get to that question for sure. But I want to go back to what you were talking about in terms of models potentially being built out from this moment. Can you talk to us about how managed care in particular might have an opportunity to improve its work with hospitals during this time, or anything that you're seeing that offers promise in that way?
Yeah, I think, one is kind of virtual. One is community wraparound resources that are becoming available for people that need them. Things that allow people to practice social distancing appropriately. I think it's around workflow resources and the wraparound services that we need in patients that are part of managed Medicaid. It's how do we reduce the variation and reduce the things that we do that we know don't work. And so I think we're going to, again, need to amplify new approaches to support people with chronic conditions and continue to know that the use of lay community health workers, helping create workforce teams that help people function at the top of their training effectively are going to be important parts of a new managed care effort. And I think we've got some good building blocks in place. There's been successes in some programs, and we just, I think, need to look at what regulations were relaxed to facilitate care delivery and what of those will work and were effective compared to ones that were not. And I think continue to move forward with those as opposed to turning them back.
Okay, so let me go ahead and pivot a little bit and talk more about research, evaluation, and industry, right? Because hospitals are able to do a lot of what they're able to do in terms of delivering life-saving medications based on vaccine trials that might come out of private industry and its work with academic institutions doing a similar thing. So are there any research and evaluation challenges or needs that you're witnessing currently or that you imagine will be forthcoming very soon? And if so, what are recommendations that you might have for pharmaceutical industries in terms of how they can be supportive to hospitals, and specifically hospitals that serve communities that have historically been under medically served?
Well, I think I would start with testing. We need more testing to understand the denominator and the prevalence in communities where there hasn't been significant cases emerge, but also in places where there are cases. And that's just to understand also the antibody testing with who's been exposed and who's not, so that we could continue to help move people towards move their lives forward, but also understand who might be at risk of being sick and how we need to take care of those folks. And so that's, I think, one area of vaccine development is another area where there needs to be continued rapid action. And I know there are a number of players in that realm, but being able to, I think, also test vaccine on not just one homogeneous population, but making sure that we're testing the vaccine on a broad, diverse population so we understand the implications for those populations. I think that those things are, I think, relevant. And then third, I would say, support for materials that hospitals and health systems and their care teams need. And I think that's the other area where some of these partners be important. I know that Direct Relief and other partners in the private sector, have stepped up to help. But there are places that can't afford some of these resources as well. So we need to be mindful of that.
Yeah, the one thing I will add, I agree with all the sentiments Dr. Bhatt mentioned. The only thing I will add is that we're starting to see, a lot of momentum gain around blood donation for those who have been positive with COVID and for whatever it is, genetic makeup or their DNA or whatever type there is. But they're starting to do some research on those patients and trying to figure out if they can donate to those who are currently in acute status as it relates to COVID and what the outcome will be. We're so premature in it. I know the Red Cross has reached out to us and to our patient population. We're partnering with them, and I've read some research across the country with everyone working on clinical trials as it relates to that aspect. We have a couple of clinical trials going on now within our ICU, but it's premature, and we're reviewing all the data, and we have to see the outcomes to make sure we have a good amount of insights to make informed decisions before we can get to a conclusion at this point.
Yeah, I think the blood donation piece is so critical in terms of the populations, particularly African Americans and those with sickle cell crisis and other conditions. And the plasma convalescent therapy can really make a difference. We've seen that work. There's also recent research emerging about ivermectin, which is an antiviral drug to treat parasitic infections that seems to be, in Petri trials, reducing the severity significantly of COVID by more than 50% within 48 hours. And so, we'll see how that emerges in trials as well. This is, in addition to the hydroxychloroquine, azithromycin trials that are happening as well.
There's definitely a lot on the horizon. And so I have a final question to you both. I've been alluding to it for some time. If you could not even so much wave your magic wand, because this is going to take a lot of work. If you could say what absolutely has to happen in order for our healthcare system to really just evolve and be able to better serve the needs of those who we are seeing are the most vulnerable, and thus making the healthcare system more efficient for everybody, what would that thing be? What would that piece be?
So I'll start off. Let me say this first and foremost. Given the current state and where we are now, I'll just I'll do a PSA and say we have to make sure that we're taking COVID extremely serious, and all of the guidelines around washing our hands, all of the guidelines around social distancing, staying home as much as possible in any event that we do need to go out for medical care for loved ones or ourselves, or we need to go get groceries, things of that nature, that we're following, staying 6 feet apart. We're making sure we're not touching our eyes, our nose, our mouth, things of that nature. We have to follow that, because that's increasingly imperative for us to begin to defeat it. Then as it relates to what we need to do moving forward in the future, it's, I liken it to, we created a bold plan here on the South Side to transform healthcare. Whereas we looked at the south side of Chicago and we said there's a 30-year gap, life expectancy gap. If you live 9 miles outside of our patient service area, you're expected to live until 90, and within our patient service area is 59. And all of our hospitals are 100 plus years old. And so we need to challenge the status quo. We need to be bold and transformative and do things outside of our norm. And we can't be satisfied with the way things have been in the past. I think communities are going to have to band together, especially communities that are vulnerable, and say, enough is enough, and work with the legislators for appropriate funding. But then the entities have a part to do as well, as they step up and invest in the communities, as well as the state level, right? And so I think we need to start doing that, and it's more than just the infrastructure that's there, but then what about the access to care sites that are needed? Do we have enough urgent cares that are there? Are there pharmacies that are there? Are we working with community health workers and organizations to get the word out outside of the four walls and the bricks and mortars? And then does our workforce reflect the community? Is a big part of it. When you look at diversity, there's a trust aspect that's there. And that trust has been deteriorated over time, right? And so we have to make sure that as you go out and we go out in the community, our workforce, our leadership should be diverse and should reflect the community that we're serving in order to gain that trust and that fiduciary love aspect that's there for delivering care. It's multifactorial to it. I think we need to be bold enough. We need to be brave enough to say, what we've done in the past doesn't work, and this is evident of it right here as we're being, we're being hit extremely hard, and it's ravaging on our community.
Yeah, well said. I would agree with all of that wholeheartedly, Rashard, and again, appreciate your leadership on the front lines of this work. And I would just echo, again, the places where we've seen this impact and be managed and mitigated is where folks have taken it seriously and have been following the guidance that the evidence suggests, and continuing to not only understand that this is not only that impacts themselves, but impacts their broader community. And I think we got to, lift up those opportunities to redesign our system, starting with the lens of diversity, inclusion, and health equity, and continue to try to push stakeholders to see things through that lens, because it'll only make our system better. And that'll be hard work and it'll take effort, but we've got, I think, great examples to draw from, and leadership that's really fired up to want to move this forward. And I think, what's interesting too is how government has gotten more engaged, and other stakeholders, even in the private sector and community, have gotten more engaged in public health and in healthcare delivery. And I just don't, want that to fade. I think we're going to need their support and energy moving forward. And so, how do we keep up the pressure and momentum to continue to have them be engaged in the important issues that impact health at a broader level, not just clinical care, but thinking about health in all policies. And I think, ultimately communities are going to also have to play an important role and collectively help with other stakeholders to move dial. But the one thing we haven't talked about much about that I think is going to be really important is the mental health of caregivers. And I think that we've got to, continue to put a priority on supporting them through this crisis and beyond, because the experiences that they've had is going to really be impactful and show up every day in their lives, personally and professionally. And so I think it's important we try to support that.
That's it. So closing words, in summation: pressure, momentum, collective support for our frontline healthcare providers, mental health moving forward, and taking advantage of this crisis opportunity moment. So thank you, Dr. Jay Bhatt, former Chief Medical Officer over at the American Hospital Association. Many thanks to you. And thank you very much, Rashard Johnson, President of Advocate Trinity Hospital and of Advocate South Suburban Hospital, which is one of my favorites, being a former staffer to Robin Kelly, whose patients go in that area as well. So I'll turn it over to birthday boy Brandon Garrett Thank you so much, gentlemen, for joining us today.
Thank you. Appreciate it.
Thank you. Appreciate it.
We can't hear you, Brandon.
Sorry, just thanks. Thanks everybody for signing on with us today and learning a little bit more how this crisis is affecting and impacting hospitals. I'm sure it's impacting you every day in your every decision that you make. So we appreciate you spending time to learn with us. Thank you again, Mia, for your leadership. We look forward to seeing you again next week. And again, if you had any questions or concerns that weren't answered, as long as you put them in the one of the chat boxes or the questions, we'll try to get back to you as well. So see you next week and hope you have a good Easter if you're celebrating. Thank you.